Hello, good evening, good day to everyone. It's great to be here once again, and thank you so much for joining us tonight. We have another very interesting topic, and we have also another very nice and very already experienced doctor and guest. So thank you so much for joining. This is Dr. Mauricio Gómez, and he is the gynecologist at Reproclinic, which is located in Barcelona. Dr. Gómez, it's great to have you here. Thank you so much for agreeing to present this particular topic for us. It's definitely going to be interesting. Dr. Gómez prepared a brilliant presentation. I have seen it already. And how are you feeling, Dr. Gómez? It's great to have you here.
Fine, thanks. Thank you, Carly, for your kind presentation. Thank you to the audience for standing this webinar in a sunny evening here in Barcelona, like today, and to Reproclinic for its invitation to present this webinar with the topic. Now you are going to look at the first slide. We are talking about poor ovarian responders from now POR, one of the most interesting and controversial topics in reproductive medicine, actually. First of all,
thank you so much, and you can just go ahead with it, okay? And I just want to remind everyone that, of course, we will start with the presentation, but remember, if you have any questions, go ahead. You can type those in the chat section, okay? Thanks so much.
Thank you, Irene. First of all, I would like to declare that this presentation is not sponsored by any pharmaceutical or medical device company. That's why you can consider my opinion unbiased. Before defining the complex concept of POR, I would like to describe the main parameters considered to define it. That are the age, the clinical markers of ovarian reserve, considered as antral follicle count and stimulation hormone, and the ovarian answer to stimulation. Let's talk about the markers of ovarian reserve. The antral follicle count is the number of follicles that can be seen on ultrasound which have the potential to be stimulated during ovarian stimulation. They are considered less than 10 millimeters observed at the beginning of the cycle, and they will be able to answer and grow after an ovarian stimulation in that cycle. It's demonstrated that less than 6 total follicles are associated with more cancellation rates. We mean cancellation as the interruption of the cycle due to a very low response during the stimulation phase. The anti-Mullerian hormone is a blood test parameter not influenced by the moment of the cycle. It's produced by granulosa cells of preantral follicles, and their values under 1 nanogram per milliliter are associated with low answers. Level under 0.4 have a predictive value of 8% for obtaining less than 4x after stimulation. Finally, the ovarian answer to stimulation is considered the number of eggs retrieved after a standard ovarian stimulation cycle. Let's talk about the importance of the age. As you can see in this graph, the process of egg reduction is genetically programmed and strongly related with aging. From the birth to the 30, the number of follicles decreases slowly until the 30. Then, the speed of follicular depletion increases, having a dramatic reduction from the 40s, as you can see. At the same way, the low-quality oocytes rate increases with the age, much earlier than you can imagine. As you can see, near the 40, it's very difficult theoretically to find eggs able to give euploid or healthy embryos. This slide reflects clearly the relationship between age, quantity, and quality of oocytes. The quality is the ability of the egg, after an in vitro insemination in an IVF treatment, to create a euploid embryo. And what's the meaning of euploid embryo? A euploid embryo is an embryo without chromosomal disorders. From now, in order not to get confused, we'll talk about healthy embryo as a synonym of euploid embryo. As you can see, and it's a very important concept, 4x as an estimated mean number of mature eggs are required to obtain at least one healthy blastocyst or embryo. With the aging, more oocytes are needed for this aim, And it's a fact that with the aging, less eggs we can retrieve. In more than 42 years old patients, we need more than 20 oocytes for obtaining at least one healthy embryo. As you can imagine, an extremely difficult chance of success in this case. Now, let's talk about the historical evolution of the concept of POR, or poor ovarian responders, as talked before. In the past, the lack of consensus on the definition made the proposed management of these patients very difficult to compare, and consequently, an ideal treatment had never been defined. From 1983 to 2011, 47 random studies were given with 41 different definitions for this concept. That's why in this scenario, the Bologna criteria was the first concrete attempt to build an international consensus in the definition of POR by following an evidence-based criteria. The main aim, agree on definitions in only one. According to the Bologna criteria, at least 2 of 3 features are required to define a poor ovarian responders. The first one, the age, more than 40 years old, or any other risk factor like endometriosis, previous ovarian surgery, etc. The second one, a previous scarce response, namely 3 or less oocytes after conventional stimulation protocol. The third one, an abnormal ovarian reserve test. However, in general terms, 2 cycles with 3 oocytes or less after maximal stimulation are enough to classify a patient as a poor ovarian responder, even in the absence of the other 2 criteria. Despite the success of Bologna definition, some criticisms arose, as the population of patients embraced by this definition was too heterogeneous in regards to women's age, oocyte competence, and risk factors. Recently, in 2016, a group of researchers gathered together to establish the Poseidon group, with the aim to investigate the diagnosis and management of patients with POR. Now let's talk about the Poseidon criteria. As you can see here, Poseidon is an acronym that means patients-oriented strategy encompassing individual oocyte number. Attending the age, the ovarian biomarkers, and the number of oocytes retrieved in the previous ovarian stimulation cycle, we can divide patients in 4 groups. Groups 1 and 2 include patients with normal ovarian biomarkers, but an unexpected low answer to ovarian stimulation. The difference between all of them is the age, less than 35 and more than 35 or 35 years old. In this case, they are divided in another 2 subgroups, depending the concrete number of eggs retrieved. In this case, less than 4. Subgroup A, or authentic low responders, and suboptimal responders between 4 and 9 eggs, considered the subgroup 1 or 2B. Groups 3 and 4 include patients with low ovarian biomarkers. That's why the low ovarian response is predicted. Group 4, older than 35, is the most frequent and the worst prognosis group. As I told before, the main aim of this classification is to stratify the groups to personalize the treatment for optimizing the number of oocytes retrieved and secondarily increase the ongoing pregnancy rate. The main reason to explain a poor ovarian responder is a reducing number of receptive follicles. As I told you before, the main cause, the age. But there are other causes of decreasing number of eggs. Ovarian diseases like endometriosis, infections like inflammatory pelvic disease, gonadotoxic treatments like chemo or radiotherapy, and chromosomal disorders in healthy patients like X-Fragile syndrome, Turner, or triple X syndrome. That's very important to ask for a karyotype in all the patients before starting an IVF treatment. But an important question is the low number of follicles the only cause of POR, or there are another? The answer is here. Not always a right dosage of gonadotropin is chosen for a complete patient, and not all the patients have the same sensibility to the same kind of gonadotropin. By the other side, it's well known that the ovarian sensibility for FSH-LH can show differences between patients, depending on the kind of FSH and LH receptors and the follicular cells. Now, when defining the concept and the main classification of POR and the causes, let's talk about the management strategies for these patients. First, and very important concept to know is that no treatment is better than other. However, every treatment can help in selected patients, and every patient should have their personalized treatment, including one, two, or several of these strategies. Let's talk about the first strategy with a real example. What may happen if we start an ovarian stimulation from the second day of the cycle without previous pretreatment with estrogens or contraceptive pills? As you can see in this upper picture, some of the follicles have been recruited before than others, and the growing is irregular and asynchronic. Just at the moment of the collection, not all of them have the same size, and the oocytes inside present different maturation stages. That's why we can take less mature eggs than expected initially. Conversely, if we use pretreatment, more choices of synchronic follicle development we have, and that's why the options to take more mature eggs increase. In this graph, you can see how we use these medications. The estrogens are given 7 days before menstruation, between 4 and 6 milligrams daily. After menstruation, 1 day without estrogen is needed, and we can start ovarian stimulation the day after. The contraceptive pills are given from the first days of menstruation during a time between 12 and 14 days. After stop them, a 5 days period of break is needed, and then the ovarian stimulation is started. Now let's talk about the ovarian stimulation conventional protocols. For a long time, and nowadays, it's been discussed which is the best ovarian stimulation protocol in order to collect more eggs. In this graph, you can see the main two, the long cycle with agonist or the antagonist cycle. The main aim of this medication is blocking the luteinizing hormone, for now LH, surge before the oocytes retrieval. And the remission is very important in order to avoid the premature ovulation that could happen during the ovarian stimulation. In the long agonist cycle, this medication agonists are started 1 week before the menstruation and maintained at the same dosage until the beginning of stimulation with gonadotropins. During the stimulation, they must be continued with half dosage until the triggering. The triggering, you know, is the final medication given to complete the oocyte maturation and must be given before the collection 36 hours, more or less. In the antagonist cycle, ovarian stimulation is started the second, third day of cycle. And the antagonist is introduced from the 6th or 7th day of stimulation, when the size of follicles, of the biggest follicles, is about 14 millimeters. They must be continued till the triggering. Recently, I have to tell you that supplementary oral treatment with progestins from the beginning of stimulation has demonstrated to be a friendly option, avoiding agonists and antagonists with similar results in terms of number of oocytes and pregnancy rates. It would be another choice to avoid the LH surge. In this graphic, in this table, you can see the comparison between both of them. The most important final concept is that there are not been stabilizing differences in pregnancy rates between all of them. But there are interesting differences related to the action. For the agonist cycle, this is the historical classical treatment, this was the first one. more tests of stimulation are needed. Nevertheless, the risk of irregular or asynchronic growing of the follicles is lower. On the other hand, the triggering can only be done with human chorionic gonadotrophin. With the antagonist cycle, less days of medication are needed, but there is higher risk of asynchrony that can be improved, as I told before, with the addition of contraceptive pills or estrogens. And the final triggering can be done with two different medications. I haven't talked about the risk of ovarian hyperstimulation syndrome because in PORs, as you can imagine, it's anecdotic. But it's interesting to know that in the antagonist cycle, we can prevent it with the triggering with GnRH agonist. Actually, I have to recognize it's more used in the daily practice, the antagonist cycle. But in some cases, for example, with repeated asynchronic cycles, for example, the agonist cycle is used with success. In patients with very low ovarian reserve, groups 3 or 4 of Poseidon, or previous with very low response with the standard high doses of gonadotrophins, a paradigm change must be done. In these cases, more hormones doesn't mean more oocytes or better results. Here there are 4 examples thought to take the same number of oocytes with less stress and less medication. In mild stimulation, a less dosage of gonadotrophins is used, starting the antagonist at the right time and triggering at the right moment. In the minimal stimulation, we can add clomiphene to stimulate the endogenous production of FSH and adding gonadotrophins at low dosage every 48 hours. After that, the triggering. And the extreme treatment of this group is the natural cycle or its modified natural cycle. In these cases, we wait the development of one follicle with the difficulty to achieve one healthy embryo. In these cases, the idea of accumulate eggs or embryos repeating several cycles is interesting. Related with the kind of gonadotrophins, no differences in pregnancy rates have been demonstrated between urinary or recombinant FSH. The decision of using one or another can be taken attending the availability, the cost, the experience, or the physician's preferences. Another question is the L8 activity of the human menopause gonadotrophin. The L8 activity is effective in all groups of POR, and it seems to be important to increase the number and the maturity of oocytes. Usually, physicians use a combination of more than one. There are new folitropins like FSH delta that try to personalize the treatment attending the AMI, the antimullerian hormone, and the weight of the patients, with no worse results. Before starting an ovarian stimulation, physicians must attend the age, the ovarian reserve markers, the answer to previous treatments, and the weight of the patients. The average starting dosage is about 150 and 225 international units or FSH, adding LH activity between 75 and 150 of human menopause gonadotrophin. It's important, obviously, the weight of the patients. Patients with body mass index more than 30 can require until 300 international units or FSH with addition of activity L8. This will be the top, would be the top. Not giving more hormones, we can retrieve more eggs. That's why more than 300 units we don't use to treat. By the other side, patients with very low ovarian reserve, as I told before, paradigm must change. We are working with less dosage of hormones. The idea, as always, personalize the treatments. Now, let's talk about 3 interesting additional therapies. The first one, the hydroepiandrosterone, is an steroid androgen precursor. It's related with a positive effect in follicular development and oocyte quality. usually between 6 and 12 weeks before ovarian stimulation, 3 times per day, is related with best pregnancy rates and less miscarriage incidence. Testosterone increases estrogen synthesis, increasing the receptors for FSH, which stimulates the growth of eggs. Applied between 5 days or 1 month before the ovarian stimulation can increase this answer. And finally, the growth hormone injected daily from the 3rd day of ovarian stimulation influences the egg modulation, increasing the ovarian sensibility for stimulation medication and promoting the early follicular development. You have to consider that there are few studies about 3 options, and the concrete protocol with high evidence levels has not been established yet. By the other side, there are several substances that added as a nutritional supplementation can increase the quality of oocytes from several ways to action. The main fact is the diminution of the oxidative stress. It may be useful for all the patients, but it seems to be better results in young patients with low ovarian reserve. We are talking about omega-3, coenzyme Q10, inositol, or melatonin. The benefit effects of a healthy lifestyle have been demonstrated in all areas of medicine. Reproductive medicine is not an exception. Mediterranean diet, frequent aerobic exercise without high impact, and other activities like yoga, mindfulness can be effective to contribute to better results. By the other side, leave toxics and having a life less stressful should be one of the most important strategies to optimize the choices, considering that the same process of fertility and the treatments become stressful. Let's talk about other strategies. The increasing knowledge of human ovarian follicular waves open new options for ovarian stimulation to improve the effectiveness and efficacy of IVF treatments. The classic theory stating that a single cohort of antral follicles grows only during the follicular phase has been overtaken by the evidence that follicles may be recruited at any time of the menstrual cycle, as you can see in this picture. Follicular cycle, post-ovulatory, and premenstrual. These offer new possibilities for control ovarian stimulation to further exploit the ovarian reserve, especially for patients with POA. And according to these evidences, a new strategy called DuoStim was applied from Ubaldi and collaborators. It consists of 2 stimulations at the same cycle. After the first collection, 5 days of stop or cleaning, and starting again an ovarian stimulation. The oocytes obtained from this second phase of stimulation, or luteal phase, seem to be at least as much competent as those obtained from the first part of the stimulation, or the first phase. In short, the increasing number of oocytes collected per ovarian cycle with the DuoStim approach may significantly increase the chance to produce a healthy embryo to transfer, especially in patients with a reduced ovarian reserve. Finally, I'd like to finish before conclusions talking about 3 obvious strategies. The first one, accumulate oocytes, may be a good option in order to increase the number of eggs, especially in patients with very low ovarian response. It's an interesting idea, but a cost-benefit study must be done, because we are talking about repeating more stimulation cycles, that means more medication, more cycles, etc. The cycle cancellation before the egg collection must be considered if ovarian onset during the stimulation is worse than expected. As we told before, this fact can happen in group 1 or 2 of Poseidon, patients with unexpected negative answer. If physicians observe this unexpected low response before the punction, they can stop the stimulation after consent with patients and try to study the cause and find another strategy for better result. The egg donor is always the last chance, and it's not the topic of today's webinar, but you have to know that it's the best choice to have success in terms of ongoing pregnancy. The most important difficulty, as you can know, you can imagine, is giving up the chance of becoming pregnant with the own oocytes and accept the contribution of a donor in the reproductive project. This is a very personal couple decision, always respected. This would be the take-home messages or conclusions. The definition of POR is not easy because there are many factors related. From all of them, the aging represents the main risk factor. Multiple stimulation strategies and interventions have been tried and used, but no one has demonstrated to be better or more effective than the others. And that's why each patient is different and the strategies must be personalized. Finally, I would like to show our nice city, Barcelona, and tell you that if you are thinking about receiving treatment or ask for any advice, we can arrange a consultation. Then how our treatments are carried out in beautiful Barcelona, and you will feel very comfortable beside our center and personally to us.
Wonderful. Thank you so much. Indeed, as I've mentioned, it was a brilliant presentation. Lots of little details and dosage of the medication you have provided. So, as always, I'm sure there will be some questions in regards to that as well. And as you can see, Dr. Gómez, there are some questions ready right here. So let's get to those. Okay, are you ready?
Yes.
Excellent.
This question from, let's start by the first one. No? Is there a best drug?
This is the first.
That increases, no? I think it's the first one, no? Mm-hmm. Yes.
Let's start with the first one from Angela, okay, and then we will go from there. So, is there a best drug, example, gonal, that increases the likelihood of more eggs?
Yes, gonal is an RFSH, a recombinant gonadotrophin. Theoretically, the bioactivity is the biggest of all of them, of all the family of gonadotrophins. But there are another hormones with the same capacity to stimulate the ovarian. We cannot talk about a best drug because, for example, gonal is a commercial name. The main active hormone is recombinant follicular stimulant hormone, and we can find the same hormone with other commercial names with the same effect. The bioactivity is right, it's good, but for example, this hormone, this product, in this case gonal, hasn't contained a rate that in some patients, especially in low ovarian responders and from an age, can be necessary to increase the quality. We prefer in our treatments, apart from gonal or any equivalent, add medications with a late activity. I'm talking about the commercial name, but it's recommended to combine with another hormone.
Wonderful. Thank you so much, Angela, for your very first question, and of course for your help with that. Next question about DHEA. There are actually a few, there's one more after that one about this. So with DHEA, I understand that testosterone is increased. What level of testosterone could be damaging to the eggs? My testosterone level was toward the upper end of normal, so I only take 25 milligrams. Could it be helpful with this dose?
Okay. First of all, we have to consider that these other treatments that I have explained, the testosterone, and growth hormone, are co-treatments that until now have demonstrated a small increase in number of eggs, in quality. In choice of pregnancy is very, very difficult to establish because we have not done any complete study with scientific evidence. But the action of the androgen that must be given between 6 and 12 weeks before starting an ovarian stimulation is increase the local follicular levels of this testosterone in order to get converted in estrogens. Obviously, there are patients with high level of basal levels of testosterone that are not the ideal patients to give this medication. That's why before starting a pre-treatment, for example, with this hormone, we used to ask for a complete blood test in order to see the levels. If the testosterone if the basal testosterone levels are high, there is more discussion for the convenience to add this medication as a pre-treatment. The theoretical dose is about 3 a day, 25 milligrams every 8 hours. In this case, it should be in discussion, obviously. But for example, in this case, it should be interesting to know about this patient, to have all the information, and if she wants to make an consultation, for example, nice to talk to her.
Of course. Thank you so much, Karen. And as you know, you can always get in touch with Dr. Gómez, his team at Reproclinic. I'm sure they will be more than happy to help you out with more details. But there is also another question from Karen. Let me go straight to this one then, okay? From the very same patient. My BMI is 32, I am 42. From the pyramid is the upper dose 300 IU FSH with 75, 150 HMG. And what is HMG?
Yes, HMG means human menopause gonadotropin. This is an hormone obtained from the urine from menopausal women that contains the same proportion between FSH and LH, follicular stimulant hormone and luteinizing hormone. In this case, for example, when we're talking about patients more than 40 years old, we have seen that the addition of this HMG can increase the answer and the quality of the eggs, for example. In this particular case, because as I told before, I'd like to talk personally with the patient, no? But the body mass index makes a bit difficult the answer for the treatment, because the more body mass index, more difficult is to answer to medication, more doses are needed in order to have the same result, and less eggs we can obtain. And the age, as I told before, makes it more difficult to obtain a healthy embryo. As I told before, I don't know if you remember, theoretically, as a medium rate, 20 eggs are needed between 20 eggs are needed to obtain at least one eutret, one healthy embryo. That's why if we add the age, the body mass index, the dose is important, but it's not the main problem in this case. But for example, apart from the FSH, talking about the stimulation, I would recommend the addition of the other hormone, but always individualizing the case. Should be analyzed.
That's, again, understandable. Thank you so much indeed once more, Karen, for that and for helping out. And so while we were talking about DHEA, let me go to the next question. I am in Canada and DHEA is a controlled substance. I had a doctor tell me there is no evidence that it makes a difference. Do you have any recommendation of studies to demonstrate its success?
Yes. Obviously, actually, I have written about it because there is small evidence in order to go about, not to go with this strong recommendation, but I can write, for example, for this patient in order to give these studies, these refers, that shows a small increase of choice of having best quality and good results. This is easy to find with PubMed and any other base data. There are studies and recent studies which are talking about this. It's important to know, as I told before, that these medications in some countries, as this patient says, are controlled substances. For example, here in Europe, sometimes it's done like a supplementary nutritional complement of tablet, and that's why there's always this discussion, no? Until what point is easy to take and to use. But the recommendation is always individualizing any case and explaining, obviously, the balance between possible side effects and benefits.
Again, thank you so much indeed, Alicia, for that question, and again for that answer. And of course, let's have a look. One more question with a little bit of details right here. I am 42, AMH is 0.2. I have done 2 IVF cycles. First cycle, oral meds with cyclogest patches, then Gonal-F 150, Menopur 300, second cycle Gonal-F 100 and Menopur 300. Due to my very poor response, both cycles were cancelled. Is there other stimulation that are used, or are the main ones prescribed?
Mm-hmm. In this case, I have to recognize we're talking about a difficult case, no? sometimes when after trying with high doses of gonadotrophins, we haven't collected eggs to find a healthy embryo or an embryo, it's a moment to think about changing the strategy. No? That's why in some cases, before arrive to the egg donor, that would be the last option, obviously, it would be possible to try the basic alternative strategies of ovarian stimulation, like natural cycles with less medication, because, for example, this is the right example that not giving more hormones, we can obtain more eggs. That's why a change of paradigm, for example, in this case, might be done. No? And obviously, taking in consideration that the choices of become pregnant with their own eggs must be really difficult in this case.
Thank you. And actually, there is a follow-up again from the very same patient. So let me go straight to this one before we go to the next question. So Jill has added, I was on Gonalev, right? 150, Menopur 300 with treatment in Ireland. Do clinics abroad use the same stimulations? Just to clarify.
Yes, this is a correct proportion. Some centers used to add more LH activity from the beginning, and this is a correct proportion. But just near the top recommended, because in these cases, as I told you before, there is a top that over this top it's not been demonstrated to have more eggs. And obviously, if we, apart from the cost of the treatment, and from the circumstances, with the treatment, not giving more than 450 doses of FSH and LH, we can get better results. For example, in this case, I consider there is a top medication option about the dosage. No? About the proportion, this is a good option, for example, yes.
Again, thank you so much indeed for that advice. And well, Anastasia has added one more question with a little bit of details. I am 33, AMH 2.9, closed tubes, had 4 unsuccessful IVF simulations, 3 short protocols, Gonalev 150, 175, Pergoveris 250, long Pergoveris 250, 3-2, 13 follicles, very few mature eggs, and maximum 1 or during the last one, 0 embryos to transfer. Which protocol medicament can I try? Sperm analysis is good.
This is a very interesting question. For example, this patient would be, as I told before, group 1 in Poseidon classification, because we're talking about a young patient. Theoretically, a young patient has better prognosis because the quality of these eggs, the possibility of having a healthy embryo increases radically, and with a good ovarian reserve. That's why the theoretical answer for the ovarian stimulation might be good. As I see, the protocols with dosage of FSH, Pergoveris, that is combined FSH-LH, and long Pergoveris, it's a very, very low response. Sometimes, I don't know if you remember that one of the possible causes of low ovarian response is a small disorder in the receptors of FSH at the cells of the follicles that can do that with theoretical good doses for a young patient. The answer is not as good as expected. In this case, obviously, it's a bad response. No? That's why there is a possibility to study a structure called polymorphism of the receptor of FSH receptor. That this is a blood test that any laboratories can do in order to see if there is any disorder in these receptors that make this patient especially sensible or resistant to any concrete kind of gonadotrophin. I can send to this patient the test in order to know that it's a possibility to see if she's a patient with a particularly receptor more resistant for the action of gonadotrophins, because obviously you have to recognize this is an unexpected negative answer. That's why more studies might be done in order to know what happens. No? Obviously, like all the cases, should be studied deeply, not in a consulting, in a webinar, but obviously here I am.
Of course, that's again, it's always the case. Yes, you definitely need all the medical history in order to properly help the patients. So, of course, always remember, keep that in mind. But I do think that it's been still very, very helpful. And as you can see, Anastasia has just answered. Thank you for this. So thanks a lot indeed. And well, there were some previous thank yous for you already from the patients for helping out, and very helpful, as you can see. Okay, let's have a look. Next question is from Angela. What success does your clinic have with women between 40, 43, 44, 47, and over 47 when it comes to live birth success rates?
Mm-hmm. This is a question very difficult to answer, obviously, because talking about success rates, if we are talking about get success with the round eggs, I have to recognize that from 45 years old till 50 years old, the choice of the possibility of having success with the round eggs is really not 0%, but near 0%, because our sisters advise from the 44, 45 years old patients that are asking for me advice in order to become pregnant is the donor eggs. I know it's difficult to tell to the patients, but the statistics really show a reality that we have to assume in this case, and you have to tell the patient, you have to be sincere, you have to be true in this case. The choices are very, very difficult. From 40 to 43 years old, it's important to say that it's very difficult because we add two difficulties. No? The number of eggs in some patients can be good with 40, 43 years old, but the bigger difficulty, the quality, as I told before, the choices of having a new embryo. No? That's why it's important to know that every year from 40 to 43 is important. I cannot give an only percentual. Talking about 20, 25% of pregnancy rate, ongoing pregnancy rates with the round eggs, 20, 25, the better pregnancy rates for the round eggs. Obviously, if we talk about donor eggs, that I know it's not today the topic, we are talking about raising the choices more than 60, 70% at the first time. The paradigm changes completely.
Of course. Again, thank you so much indeed. And Angela has, okay, and about live birth success rates, anything you can add?
Yes, connected with the other question. The same. You have to consider that from 38 years old, not from 40, from 38 years old, we strongly recommend the embryo biopsy in order to study if it has chromosomical disorders, the PGD or the PGT, depending the nomenclature, the name. That's why this is the most difficult step, because the choice is to have an euploid, I insist, a healthy embryo from the 40 years old is not easy. When we have taken this healthy embryo from these cases, obviously the choices increase dramatically to the 80%, 90%, because the quality of the embryo is the most important prognostic factor to have a healthy baby in this case. Not only pregnancy test positive, we are talking about ongoing pregnancy and a healthy baby.
All right. Yes. And after PGD, there is a follow-up again.
Yes, PGD is prenatal genetic diagnosis. Actually, it's called PGT. There are small differences in the terminology, the nomenclature, but correct, yes. Prenatal genetic diagnosis. Because it's performed before transferring the embryo. That's why it's, in this case, it's pre-implantational, excuse me, not prenatal, pre-implantational genetic test.
All right. Thank you so much. And one more, okay. So when would you advise for women over 40 to stop treatment if no success and to use donor?
It depends on many factors, obviously. It depends on for example, the number of eggs and finally the number of embryos get after a treatment. For example, if from a first ovarian stimulation we take less than 3 eggs, a low ovarian response, and from these eggs we are not able to achieve any embryo, maybe any embryo to study, to make this study genetical pre-implantational. That's why we talk with the patients. Sometimes a second option, a second try, with different kind of stimulation, with different strategy, we can try, waiting for another better response, but always thinking about taking a few months. If after 1-2 treatments, there is a moment in which a physician talk to the patient and try to consent the possibility to accept the fact of arrive to a donor. This is depending obviously of every case, every case.
Thank you, Angela, for your questions. And now, of course, for your help, sorry, Dr. Gomez. Now, there is a question, quite a longer question. Let me go through it. I will read it out. And of course, let's take part of it one by one. So I'm 41, BMI 22, AMH 1.8, AFC 3. I had one natural modified cycle, Bemfola 150, Cetrodit 125, Ovitrol 250. My cycle is 27 days. I started injections on day 5 and had the egg collection on day 10 already. I had 2 follicles of the right size, but unfortunately no eggs were collected. The doctor's feedback was just that it sometimes happens and that it's likely because of my age. How often do you come across empty follicles? I have read that if the collection is done too early, the eggs are not released yet. Also, that collection exactly 36 hours after the trigger are not suitable for everyone. Thank you so much, Michael, for that question.
In this case, there are many things to comment. No? First of all, the age, 41 years old, all right, with the body mass index. For example, here there is 2 ovarian reserve markers, no, anti-Mullerian hormone and antral follicles count, give different information. For example, it's not normal to think that from an anti-Mullerian hormone of 1.8, depending the units, if they are nanograms per milliliter, it's not normal to have only 3 antral follicles count. That's why maybe a difference of concept. Maybe this anti-Mullerian hormone is not real, but obviously I think we are talking about a low ovarian reserve patient with 41 years old. That's why from the beginning it's a difficult case to achieve pregnancy with their own eggs. This natural cycle modified with, it seems to be correct, the concept, no? With a moderate doses of Bemfola, that is like Gona, for example, is FSH recombinant. Cetrodit is like the antagonist, exactly, and Ovitrol. About this case, for example, it's talking about the triggering. No? We haven't talked about the triggering, but when the follicles are just to be taken off 2 days before the ovarian collection, we use 2 kinds of medications, this Ovitrol and the Capeptil, that is a GnRH agonist. Sometimes we have found that after the day of ovarian retrieval, we are not able to take eggs from these follicles that theoretically were ready, no, with the eggs. There are many hypotheses to justify this, but sometimes this empty follicle syndrome, that is difficult to give this diagnosis, no, with this case, may be due to the triggering, no? When this situation happens, if we try another cycle, we like to do one thing called dual triggering that represents for the final maturation of this ovulation, giving put together, in this case, Ovitrol and the Capeptil. In these cases, the thing we are doing is stimulate the final maturation from both different ways, from 2 different ways. No? And it seems to be that can better the result of obtaining eggs in patients with a previous case like this, no, previous stimulation, with an empty follicle. But apart from this, obviously, it's impossible to know from my side, no, how was the ovarian stimulation, the egg evolution, the follicles evolution, in order to know if they have been discharged just at the right time. No? I know if really this case, how has it been in this case.
And thank you again, of course, Lenka, thank you for your question. And Dr. Gomez, thank you for helping out. And I'm sure it has been helpful. We will be slowly finishing. Okay, so of course, if you have any questions, go ahead, type those in. This will be like the final call for the questions. And there's a thank you from Lenka for your help, of course, here. And let's have a look. Karen has added here one more question. Thank you for explaining about the HMG. I read previously that if you go over 300 units, it can be damaging to the egg quality. Is this research now outdated, or is it that because FSH and HMG are different stimulation medication, that more than 300 in total is not damaging?
Mm-hmm. This is a very good question because there's an opinion from some groups that in order to justify increase the quality of the eggs and increase the quality of these embryos and the possibilities of having a new product, a healthy embryo, they relate with the dosage of hormones. This natural current opinion that talking about decrease the doses of stimulation in order to have less eggs with best quality, it's very controversial, because when we are talking about having become a healthy embryo, we prefer to have from the beginning more eggs, considering that from the beginning it's like an obstacle race. More eggs we start, more choices to have an embryo. But when we are talking about patients with low ovarian reserve, sometimes the idea of decrease this ovarian stimulation can produce the same amount of eggs, but with less pharmacological or hormonal stress. This is an interesting theory. There are studies about it. Always difficult to be absolutely evident, but this is an interesting question. How our philosophy from the beginning till finding a very low ovarian response is try to rise, to start with a good dosage of stimulation in order to have more eggs. If after the first time we are not able to get a normal number of eggs, that's why we change the strategy, and in these cases we try to decrease the dosage in order to have a better quality, considering not more hormones means more eggs. About the number of the dosage, as I told you before, we use top hormonal level between FSH recombinant and HMH, about 375, not more dosage, really. These combination treatments between recombinant FSH and human menopausal gonadotropin are very, very usual in order to stimulate the ovarian from both sides, so both different kinds of hormones. The FSH, like a colloquial term, is more laboratory, is more synthetic hormone. The human menopausal gonadotropin is more natural, it's coming from the human patients. And with this extra LH activity that seems to be useful in patients with low ovarian and with aging.
All right. And actually, Karen has one more interesting question. Okay, so let's get to that. Do you sometimes do double trigger in these cases? Orbital pens with GnRH, should they be taken at different times?
In this case, the dual triggering we do with one orbital pen with 0.2 milligrams of the capepil, 2 small bottles with medication. We administrate, maybe separated half an hour, and before 36 and 34 hours before the ovarian stimulation. We used to separate, yes. There are different theories about this, the separation between both of them. There is an antifollicle, sometimes some physicians used to give, first of all, the capepil, or in this case, generate an in order to stimulate the discharge of the LH after 36 hours, And 36 hours before, we add this ovitriol. Some physicians, for example, as me, prefer to do, first of all, the capital, just 36 hours before, and half an hour later, ovitriol. Because theoretically, the action can happen at the same time, just at the ovarian retrieval.
Excellent. Thank you so much, Karen, for your amazing questions, detailed ones, but of course, definitely interesting. And Dr. Gómez, as always, it's been, again, helpful, so thanks a lot. Someone is typing, okay? So I just want to see whether it's another question or if it's a thank you, because we will coming to an end. But there is one more, okay, from Karen. So it's fine. No worries, Karen. Thank you so much indeed. Really helpful. Do you have the name of some studies I can read further? So you suggest more HMG and less FSH with low ovarian reserve. My AMH is 6.1 PMOL and 6 follicles. Retrieval is low, however, with 2X collected.
Mm-hmm. Related with the name of some studies, obviously I've got them, not now. That's why I can share to her, obviously. And the next question, let me see, so this is just more. Mm-hmm. Yes. In this case, for example, it's a personal decision, no, with obviously with the scientific evidence. I like very much the human menopause gone out of it, considering the balance between both hormones given from the beginning, no? With a bit of FSH activity, it shows to me good results, obviously, with the reality, no, of low ovarian reserve, for example, in this case, because we are talking about a low anti-mullerian hormone in this case, because it's in picomoles. Well, related with the number of follicles, it's always, we always can try with 6 follicles. Mm-hmm.
Thank you indeed, and that it looks like that was our final question. So thank you everyone for joining us, for your all the detailed questions indeed. And Dr. Gómez, this has been really good, great session with lots of details. And this is a topic, not an easy topic, I guess, as well. So thank you a lot for explaining everything. And as you can see, there are some comments coming up for sure. Thank you for your presentation. And of course, there is another one from Alice right here. So yeah, Karen added one more. Thank you so much for wonderful presentation, Q&A. Much appreciated. Definitely. It's been really, really great to have you, Dr. Gómez, here with us. And well, before we finish, is there anything at all you would like to add?
Thank you very much.
Thank you very much then. Of course, have a lovely evening, everyone. Remember, it has been recorded, so if you would like to find, just have a look at this once again. It will be available tomorrow on My Abby Fences, but also on our YouTube channel. So I can only encourage you to subscribe so you will know when the video is uploaded. Dr. Gómez, it has been a pleasure. Thank you so much. Have a lovely evening, everyone. And I hope that we will have a chance to repeat this once again, Dr. Gómez, okay?
Yeah, the same.
Thank you so much.
Good evening. Bye-bye.
Hope to see you, of course, everyone. Remember, we will be back on Thursday. There are 2 webinars on Thursday, so don't miss it and join us. Thanks so much. Bye.